I don't know if
This meeting is being recorded.
Ooh, there we go. Ever worked in this much tech before, so bear with me if it doesn't end up working out. All right, welcome. Glad everyone could join us here today. My name is Julia Foster. I am a physical therapist here in Kansas City, Missouri. I have been working in the pelvic health industry for 2 years since graduation from PT school at KU Medical. And I actually last year did a residency in women's health, learning from experts in the field at Washington University in St. Louis. And so this topic is near and dear to my heart. Although I do not have any kiddos of my own, I help mamas and mamas-to-be every day at my job in my clinic, kind of just like helping them achieve their highest potential and kind of talking through what we're going to talk through today and preparing for birth and kind of just getting a little bit more grasp from a pelvic or like a physical therapy lens. A lot of birth prep classes focus on different techniques for pain management and partner support and different aspects of the medical side of the labor itself, with medications, what to expect, how to count your contractions, things like that. Now, what I want to kind of focus on here today is really talking through what can we do from a biomechanical standpoint as well. I also have here with me today Marla, and Marla is also a pelvic physical therapist at our Foundational Concepts Clinic in Brookside, Kansas City, and she will help be monitoring the chat. So if you guys do have any questions throughout the presentation, Marla will also help kind of answer those as we go. And then if we have any that may be good for discussion or waiting towards the end, then we can also kind of tackle those later. Last thing I want to just touch base on is before we get started, this is for informational and educational purposes. And so this is not considered medical advice. So if you do need medical advice, it's better to consult with your OBGYN or your pelvic physical therapist to get an individualized approach based on kind of your history, injuries, your needs, and your pregnancy and health. So with all that being said, let's dive in. Here on the agenda today, kind of our key items for our push prep are just a little tidbit about pelvic floor, positioning for labor, perineal massage, pushing and breathing mechanics. And then we'll also kind of dive into the end at kind of a little few extra tidbits as well. So what exactly is the pelvic floor? Earlier, I introduced myself as a pelvic floor physical therapist. And so what is the pelvic floor? I feel like kind of that term gets thrown loosely around, especially with like TikTok, social media. It's like all the craze is pelvic floor. I'm sure you guys are having it pop up all over your feed. And so I wanted to include kind of two different visualizations of the pelvic floor here. So here on the left-hand side, you can kind of see that all of the muscles here are kind of spanning from the front where kind of your pubic bone would be to the back where your tailbone is. And so these muscles from the front to the back, but then also side to side onto either of your sit bones. And so these muscles of the pelvic floor connect onto the pelvis, which is really important, okay? And so kind of why that matters is because our pelvis and the way that our pelvis moves influences the pelvic floor, which we'll dive into later. Now, in kind of like everyday, here and there use, really important functions for the pelvic floor are 4 different things. So this kind of like first layer here that you can kind of see around the vulva and the anus are really important for sphincter control. So sphincter control is the closure or kind of the circular contraction around the urethra where urine and your bladder would then empty, urine would exit, around the vaginal canal, also kind of like making that loop there, and then also around the anus. And so kind of that sphincter control is really important for keeping bowel or bladder kind of control, decreasing any incontinence, but just as importantly is being able to relax those muscles in order to completely evacuate your bowels or completely empty your bladder. So it kind of goes both ways. Now, another thing that's really important kind of in this first layer, you can see it does kind of wrap right around the vaginal canal, okay? And so this layer is also really important for sexual function. And so kind of with these muscles of the first layer, they contract and relax to bring blood flow to the erectile tissue that sit on either side of the vaginal canal and kind of up towards the head of the clitoris here, to bring blood flow to that area for arousal and orgasm purposes too. And so sometimes kind of what we can address even postpartum is that if there is any tearing, typically what would happen is that the tearing, not 100%, but typically I would say that it usually tears kind of posteriorly or towards the rectum. And so with that being said, sometimes it can influence some of these muscles or cause a little bit of scar tissue in that area, which then can affect the sphincter control or sexual function later down the road. Now you can also see that there's these like deeper muscles, kind of like right by the anus here, but it's kind of like a layer back. And so that deeper layer is really important for now two other functions, support and stability, okay? So now if we take a look over at this right-hand image, the support, you can see it's like these muscles, or you can kind of see like that sling that is just like acting as a shelf for your bladder, for your uterus, fetus, and then rectum too. And so kind of your support comes from these muscles being able to hold all of that up. So especially as like baby and belly start to grow, it's like, ooh, because sometimes you can feel a lot of heaviness or pressure at the pelvic floor because those pelvic floor muscles have to work really, really hard. Last thing is stability. And so these muscles also connect onto the pelvis, like I was saying. And so especially with stability, it works together with your deep core, your transverse abdominis to kind of provide that support there. So that's just like day in and day out, right? Now, when it comes to labor, here's the trick. We actually just need pelvic floor to relax, get out of the way. Uterus does the pushing here. And so your uterus contracts, and those contractions is actually what guides and pushes baby out. So especially when we're thinking about preparing for labor, we actually need a pelvic floor that has the ability to lengthen. And so a lot of times we get caught up a lot on the strengthening aspect, but we have to remember how to let go, how to relax those muscles as well. So we'll kind of touch base on a few different things that may help out with that. All right, so let's take a look at the pelvis. I get way too excited about these things. So what we're gonna look at is on this left-hand side, you can see that's just like the bony pelvis. And so kind of like where your hips are, if you put your hands on your hips, is actually way up here. And then your hip socket, like actually where your femur is inserted, is actually way down here. And so we kind of think about like, oh, my hands are on my hips. That actually is called your iliac crest, whereas your true hip joint is a little bit lower. So kind of why that matters is you can see all of this red here. All of those are those pelvic floor muscles. And so kind of if we take a look over to the right-hand side, you can see these joints, they actually do move. And so kind of like whenever we are rehabbing, it's like we use these mechanics all the time to kind of like educate patients on kind of like different postures and positions that, you know, if they have like any SI issues or hip issues. But why don't we use these same kind of like mechanical principles during labor? So that's what we'll talk about today. So kind of this top picture here, you can see kind of the top part of the pelvis is opening up, okay? So the bottom part is getting narrower, the top part is opening up, okay? So in order to achieve that motion, what has to happen is the sacrum has to tilt backwards, which is called counternutation. The spine has to flex, and the hips externally rotate or turn outwards, okay? And so by doing that lumbar flexion where you're kind of flexing forward and turning the hips out naturally helps the sacrum counternutate, which kind of gives a little bit more space at the top of the pelvis. Which, think about this, it's like if we are in that like first stage where we're trying to get baby to descend down, the head to descend down towards the cervix, towards kind of like exiting, then we need to open up that top part first. Now, as baby descends a little bit more, all of a sudden you are dilated to 10 centimeters. Your body, your physician, they're saying, okay, it's time to push. And so now vice versa is actually, if we take a look at the bottom picture, that's where you can see, okay, actually now we need to spread the bottom part out, which makes sense, right? If we spread the bottom part out, then we are getting more opening at that rim in order to allow baby to exit. So in order to do those motions, actually what we have to do is turn the hips inwards and extend through the spine a little bit. Okay, I would say if you had to kind of prioritize one or the other, your hip position probably matters more. Okay, so let's talk about that. So the first stage, like I said, we want to open the inlet or the top part. So your motto for that kind of like first stage, while you're kind of getting ready to dilate, you know, you may kind of like be starting to kind of pick up on contractions. They may be coming more frequently. Cervix is dilating a little bit more, but it's not time to push just yet. So in this first stage, we are kind of thinking, okay, legs turned out. So a few different variations that you can try is hands and knees, kneeling, side lying, and a wide squat, okay? So let's look at those. So I took some pictures. Some of them are kind of funny looking. Maybe I just think that because it's a picture of me, but maybe it's not funny looking. Okay, I digress. So legs turned out. You can kind of see I put that picture kind of right in the middle here of what's happening at the pelvis. And so if we're taking like a back view, when your legs are turned out, it really opens up the top. And so you can kind of see that in that middle picture there. So kind of different variations, wide squat, like I said, putting something between the legs. Now, I didn't have a peanut ball at our clinic, so I had to use this like giant exercise ball. So like that looks super aggressive, that how wide my legs are in that top right picture, but you get the point. So think like butterfly legs, okay? So first stage, butterfly legs, turn the hips out, okay? So you can try out all of these positions. Sometimes, especially in this first stage, like use gravity to your advantage. Like if you have not had an epidural yet, or if you're not planning to get an epidural, then sometimes more upright positions, like if you're sitting on an exercise ball, if you're standing, swaying, kneeling, kind of all of those positions can also kind of help, just because gravity is then allowing kind of that assistance there. So if we then think about the second stage, now we actually want to do the opposite. So knees turned in. And it's like funny because it's like, at least when I think, before I kind of like got into this field, I always think of like in the movies, it's like, okay, they're always laying on their back and their legs are out to the side, or like kind of in more of like a butterfly position. And so actually what may be more beneficial is to bring the knees in a little bit more narrow. So some different kind of variations, and I actually did put some asterisks here, so that way if you do have an epidural, or if you do plan to get an epidural, then you can kind of like think through some of these positions. Now, I will say transitioning into some of these positions, if you do have an epidural, may be difficult, but having partner support, and nursing staff support is going to be really, really key to just, talk through with your physician, see if this is a good option for you. But know that, it is an option out there. So hands and knees, side lying, tall kneeling, narrow squatting this time, supported lunge, and then lying on your back variations. So now the biggest one that I kind of want to highlight, if you take your eyes to the middle picture here, as you can see, when my knees are turned in more, now look what that did at the tailbone and at the kind of opening or the bottom part. It's like, okay, there's so much more visibility that you can see to kind of open up through the bottom part of the pelvis. And so in kind of the second stage, this is the pushing stage, okay? And so being on your side, you could put pillows or a peanut ball in between the feet now. And so if you're putting it between the feet, actually, then that'll let the knee kind of fall inwards more, which will actually help open up the pelvis. Same thing with hands and knees, or you can kind of see in the middle, I'm kind of leaning on a ball there, but you could also lean like on the bed as well. Now, the ones all the way to the right-hand side, those may, if you do have an epidural, they may be a little bit more tricky. But if you're planning to not have an epidural, again, have those in your reservoir. Have it in your back pocket for different options. All right, and then I loved this picture. I actually got this image from another pelvic physical therapist, Mama Stay Fit. And it just kind of goes through kind of what I was saying earlier. It's like, okay, when we think of like, if we're on our back and our legs are out, okay, maybe that might kind of close down the pelvis a little bit more. But there is indication sometimes that either if physician or nurse are needing to visualize the tissues, then it may be indicated. But you can always kind of bring this up and voice your concerns like, hey, would you be okay if I try a little bit more of a narrow stance when I'm pushing? But ultimately, the decision is like, listen to your body. It's like, if you want to push on your back, if you want to push on your hands and knees, it's like, kind of listen to see like, what feels good with what you are sensing? What do you feel like your body needs? And so kind of like the best position is one that you feel confident in. And so like, that is why I really wanted to just like touch base on kind of like a lot of different options, because I think that kind of like with like the anxiety and the nervousness that can happen going into labor, the actual nervousness and anxiety can sometimes lead to more complications. And so if you feel confident in what you're doing, if you feel confident in practicing these things before labor, then that's going to instill your confidence going in, leading to better outcomes, better expectation, and a better birth experience. Now, I always say to all my mamas, it's like, we can go in with like an ABC plan, and sometimes it does not stick all the way through, and that does not mean you failed. That does not mean that you did something wrong. Every baby, every body, every birth experience is so different. And so just remind yourselves of that as well, okay? All right. Moving on to perineal stretching. You're like, what is perineal stretching? My goodness. So perineal stretching, if we come back to those muscles of the pelvic floor that we were looking at earlier, perineal stretching is stretching of those muscles. And so actually this perineal stretching practice began while in labor. And so it was used by doulas or nurses during labor to actually stretch the perineum to allow baby to come through and those tissues to relax and extend. Now, there is research that does show that doing the perineal stretching during labor, now you won't be able to do this yourself. It would have to be done by a nurse or a doula or a support staff in that area, but it does reduce the risk of grade 3 and grade 4 tearing. Now, one thing that's interesting that has been kind of proposed is that we could actually potentially start this perineal stretching during pregnancy. And so with your physician's approval, it can be started around 32 to 34 weeks, okay? Everyone's kind of different on how often they'd like to perform it. Some people tend to do, twice a week starting out. Some people like to hit the ground running and do it every day. The next slide is going to talk through kind of instructions, but again, make sure you have your OBGYN's approval. So if you are on pelvic rest, if you have any indications of a cervical disorder like a cerclage or premature rupture of membranes or anything that may contraindicate internal stretching, that's just something that we want to keep on our radar, and we just want to be passing through with our physician first before starting this out. Okay. When you're doing the stretching, you can use kind of a partner like pictured here. You can use your hands, or you can even use a pelvic wand. So you're like, what is a pelvic wand? My goodness, Julia, you're throwing lots of things up at me right now. So that purple thing up top, that is a pelvic wand. It's basically an S-shaped curve that is used to perform the stretches. And so especially if like belly and baby is getting in the way, that wand can really come in handy here. And so if we think about like the pelvic floor as a clock, you can kind of see that clock in the upper left-hand corner there. Imagine like, okay, 3 and 9 o'clock would be like kind of just going like directly side to side. So you really want to stay between 3 o'clock and 9 o'clock. You don't really need to do any perineal stretching from kind of that upper half of the clock. I would kind of stick down to kind of the side to side and then kind of towards the rectum here. Now kind of with the pelvic perineal stretching, make sure wash your hands beforehand, apply a clean ingredient water-based lubrication. Our favorites are Good Clean Love and Slippery Stuff. They're both glycerin-free and paraben-free. I can drop that in the chat later, or if Marla, you want to just kind of write that out really quick in case anyone wants that for a reference, that would be awesome. So use a water-based lubricant and then apply it to your fingers or the wand here. So what you're going to do is use the wand, okay? And then imagine kind of like inserting either your finger or the wand about 2 inches or so. So if you're using a finger, it's about to the second knuckle, okay? You don't want to go really higher than that because the first 2 layers of the pelvic floor are about at that kind of like depth. And so you don't need to go much further than that. And so about to that second knuckle, and then you're going to apply that stretch over to the right and then over to the left, okay? Then kind of down at, I'm thinking of my clock here. Oh gosh, down at 8 o'clock, 7 o'clock, maybe skip 6 o'clock just because putting pressure directly on the rectum can be a little bit uncomfortable, especially if you are suffering from any like constipation in that 3rd trimester. And then 5 o'clock, 4 o'clock, okay? So each kind of like area on that clock, you want to hold that pressure for about like 10 deep breaths, okay? And this is actually a really, really good opportunity in learning how to breathe through discomfort and kind of like allowing those tissues to stretch during discomfort, okay? Because just our natural instinct when our body is in pain is tense and guard, right? And so it's going to be natural to, this feels uncomfortable, wanting to like guard and like tighten up. It's like, okay, let that muscle go, let that muscle go. At first, when starting out with the perineal stretching, it can feel kind of almost like a burning type sensation. And sometimes that can be a referral from one of those muscles called your bulbospongiosis. It's kind of notorious for kind of instigating that burning sensation. It may be uncomfortable, but it should not be painful, okay? And so if it's painful, kind of like back off that stretch a little bit, okay? You can repeat up to daily, or you can do this just a few times a week, okay? As you're kind of progressing further towards your delivery or your anticipated due date, then that's when I may kind of suggest, okay, what if we tried 2 fingers, kind of like more of a like circumferential stretch during that time. All right, awesome. Moving on. Okay, pushing mechanics. So kind of two major categories is open glottis and closed glottis. So I tried to use two different memes here, but my open glottis meme was like not working. I tried to use the one, I don't know if anyone like loves sending GIFs or GIFs, however we want to say it these days, to friends, but there's this one where a kind of older lady blows out birthday candles and she like loses her dentures. It's pretty good, but it wouldn't copy on here for some reason. It wouldn't like play through. So I'm like, just picked birthday candles instead. So open glottis, your glottis is in the back of your throat, okay? And so your glottis is kind of, think about it as like your vocal cords. And so whenever we close our glottis, that's what's considered a valsalva, okay? So we're closing off kind of the pressure in the back of our throat, which, because we're closing off the pressure here, that actually traps that pressure from your neck down, so into that abdominal area. And so kind of that closed glottis pushing increases a lot of intra-abdominal pressure. So a lot of times, especially when kind of like we're thinking about the pushing, again, we always kind of imagine maybe, or maybe again, it's just me kind of just seeing it in different movies, but we imagine that kind of like holding your breath and kind of pushing down. Well, since that increases a lot of abdominal pressure, that's a lot of pressure coming down on that pelvic floor. Versus if we do an open glottis, basically what that means is you're not closing off kind of that restriction there. And so you are still trying to guide your pressure downwards, but not so much that you're kind of like restricting it from here down. And so kind of an open glottis technique would be more of a blowing out, like a huffing, a humming, gurring, even kind of like those like low tones. Okay, so those low tones may kind of help guide that pressure downwards. If you've never tried it before, honestly, practice it. Give it a go. It is a lot trickier than you think, especially if you're thinking back and you're like, if I have bowel movements, I'm on the toilet and I'm doing that right hand, right-sided one where you're holding your breath and pushing down. Try not to do it, okay? That also increases kind of that pressure downwards on the pelvic floor. Now, kind of like the most recent kind of like guidelines and kind of like sets out there really kind of advises you to, again, listen to your body. And so if you feel like you're trying kind of that like 10-second hold your breath push and you're feeling like a lot of lightheadedness, dizziness, that you feel like you really can't get a good because you're losing your breath, try the open glottis, try the huffing, try the humming, try the pushing. If you've been trying the open glottis and you've been trying the pushing out, okay, and you feel like, ooh, I just really want to give it like one good push, what I do want you to try is that if you do try that closed glottis position, instead of doing the full 10 seconds, maybe just try 6 to 7, okay? That'll be kind of like more protective of kind of like pelvic floor. You won't have as much pressure downwards, but that also will give you a little bit more time to kind of like recoup, okay? Sometimes I kind of give an example of like, if you hold your, if you were a diver or like a swimmer, it's like you probably could do this no problem, but like, I know if I held my breath and tried to do an activity, it's like, I'd feel like really out of breath. And labor is a very active event. And so we do need oxygen to those tissues in order to successfully kind of like bring blood flow to that area, lots of oxygen, lots of good nutrients. And so like, just make sure it's like you're listening to your body and no matter what you decide. And then practicing that open glottis pushing literally as like an exercise heading into labor can be good just as a alternative, which may be protective of the pelvic floor. All right, one kind of plug here for partner support. If I have anyone else joining us and watching apart from our pregnant individuals, if you have a partner and they're wanting to, ask, what can I do during labor? Coaching you through that breathing. So, hey, I'm about to hold my breath. Like, I think I'm gonna try some closed glottis pushing. Count me down from 6. Okay. So like, that's kind of a good established thing that you guys can kind of practice before. Or, hey, if you notice me really kind of losing my breath, maybe kind of remind me, oh, can I try that open glottis pushing, or the huffing, the blowing, the humming. Also positional support. So I loved this top left picture and the little positional support, because it looks like he's just kind of giving a little neck rub, and I'm like, yeah, it's okay, sometimes, especially whenever kind of those pain signals are coming up, it's especially a back rub at the lower back actually can be really beneficial. And so there's this thing called the gate theory of pain. And so with kind of the gate theory, basically imagine if you stubbed your toe and all of a sudden you go to rub your toe, or you knock your funny bone and you're oh, this really hurts, and you're kind of rubbing it. It's actually what happens is with that pressure or that rubbing or that kind of stimulus to kind of that part of the body, actually sometimes that can kind of beat the pain signal to the brain, which can help diminish that pain from the contractions, from the uterus, from that stretch. And so it's actually pretty beneficial. Another kind of option for that pain relief can also be a TENS unit. You can do both, again, with or without an epidural, but something to talk to your physician about. A TENS unit is essentially a little handheld device that just kind of through electrodes gives you kind of a little bit of a staticky type feeling, and so that can be good. Other positions kind of that can be a good support is that if you're in that deep squat, kind of hooking under the arms, wrapping a towel around kind of your bottom to try and hold you up a little bit more, wrapping a towel or sheet around kind of hips and belly if you're in a hands and knees position, and having your partner stand above you. And then lastly, kind of a good one in any position, but it may be easier to access in a kneeling position or a hands and knees position, is some counter pressure. And so if you guys remember kind of the difference between the opening, the inlet versus the outlet, is that if we were to push down low, actually at the hips, your true hips, not your iliac crest, your hips, then that will help kind of open up the top part. And so that'd be kind of a first stage go-to is pressure low, versus second stage, pressure up high, pressure at that iliac crest, or kind of if your hands are on your hips and you're kind of feeling that bone way at the top, that kind of pressure right there. So providing counter pressure can also have a good relief too. So, not that you guys asked, but I do want to give you guys just some homework to think about. Try practice pushing. Pushing with relaxation and lengthening through the pelvic floor muscles in different positions, maybe 10 minutes a week. Get comfortable with kind of transitioning into those different positions, breathing in those positions, breathing through discomfort. I've seen so many recommendations for this, people holding ice cubes, squeezing combs, holding a wall sit, just so many different things to try and practice breathing through discomfort, even trying that perineal stretching. Practice partner support, so that way they also feel confident and comfortable going into the experience. And then practice using props, where should I put the pillow? Where should I put a sheet for kind of support? And then also, if you don't feel comfortable with the pushing and you're I don't know if I'm doing the relaxation, what you can try is even having your partner or yourself kind of hold a handheld mirror. And what you actually should see is kind of the muscles around the anus and the muscles around the vaginal opening. You should see them lengthen and kind of come downwards. Now, if you feel you're doing that pushing and all of a sudden you see a whoop, a squeeze or like a contraction around the anus, then that may be a sign that we're actually doing a paradoxical contraction and we're actually needing to kind of teach those muscles how to relax. And so it is really hard. It takes a lot of practice. If you feel like you're getting frustrated and you just can't get it, that may be kind of a time to get into a pelvic PT. Last thing that I just kind of want to talk through is that if you are trying these different positions, and then especially if you do have any prior injuries or pain during pregnancy, like if you have, for example, a prior meniscus tear, ACL, hip labral tear, pubic symphysis pain, sciatica pain, a bulging disc in your back, if any of those things are getting aggravated by trying some of these different positions, it may be beneficial to also get a consult with a PT, just to get an individualized plan, just to make sure that you're doing everything to set yourself up for success, both during the delivery and into that postpartum period. Okay. All right, before we open up to questions, I just kind of typed a few other questions that I think may be worth discussing with your OB, especially just after kind of talking through here today, based on some of these recommendations. So big things, will I be able to move around in bed if I have an epidural? Do nurses or support staff help with this? What are my pain management options? Is there a window I have to be in during labor in order to receive my epidural? Typically, the answer is yes. And then if you miss that window, what are my options for relief? Do they have TENS units? Do they recommend, ice or heat or any strategies for pain relief? Can I try these different positions that I learned about here today in labor and delivery, or use these props? Are these props already provided at the hospital, or do I need to bring them myself? How many support people are in the room allowed with me in the room? So can you bring a doula if you have a doula? Can you bring a partner? Can you bring both? And then also, if you do end up having a grade 3 or a grade 4 tear, who repairs them? If they're done bedside, if they're done in the OR, if they are typically done by a urogynecologist, or if they're done by your OBGYN, then those are all things to just kind of just discuss before heading into the big day. I just want to thank you guys all for coming. I hope you guys enjoyed. And then with that being said, the last thing is I just want to thank kind of our host and our sponsors, Foundational Concepts. It is a specialty physical therapy clinic in Kansas City, and we have 3 locations in Brookside, Overland Park, and in North Kansas City. And we have an awesome team of PTs. So if you do have any specific individualized questions that kind of need a little bit more in depth or an individualized assessment, we'd love to help you out. We always have a free 15-minute consult available. So if you're like, I don't know if I'm right for PT right now, you can also call us just to schedule that too. All right, I'm going to stop sharing my screen and open the floor to any questions. Oh, and I'm already seeing some in the chat. Perfect. So from Alyssa, I have a question. Any tips on prompts or language to better advocate for pushing positions? I was not really given options the first time around. Pushed on my back and didn't love it. So Alyssa, I think that definitely is something that a lot of people can resonate with, right? And so I think that even talking with your provider heading before delivery, kind of like setting that expectation of like, hi, I'm really interested in trying to push on my side, trying to push on my hands and knees, or whatever kind of position that you're interested in. Set that expectation heading in and kind of see like, in kind of like make that communication established even before the big day. And then when you're kind of in the moment, this is when partner support can really come into play. And so kind of advocating both for you and for your body, just making sure that you're kind of doing what's best for your body. And if they do kind of recommend a certain position, maybe just kind of following up with like, is there a certain reason? Is it because they're trying to monitor fetal motion? Are they trying to, or vitals? Are they trying to observe the perineum? And just kind of making that clear, like, okay, after we're done with that assessment, can we then transition to a different one? All right. And then another one is, yeah, of course. Another one is, which doctor would be best to stitch up a 3rd to 4th degree tear? Connor, that's a great question. It really depends on the hospital, kind of based on like what procedures they have available. When I had my time in St. Louis, typically a 3rd and 4th degree tear was if there was an urogynecologist present, that they would do it. But a lot of OBGYNs are excellent in kind of this field as well. And so just kind of, again, advocating for yourself, kind of seeing like, okay, if you're told you have a 3rd or 4th degree tear, who will be doing the repair? Is it the fellow? Is it a training resident? How much experience do they have? Do you have rapport and trust with that provider already? Again, just advocate for yourself. I think is kind of the best way to go, and kind of see what different hospitals and policies are. It kind of just depends on how big the hospital system is too, and who's available. How do you differentiate between a first stage versus a second stage? How many centimeters dilated? Yeah, great question. So your second stage is when the cervix is completely dilated. So that is when you will start to feel the urge to push, and you'll be instructed in pushing. And so they may they'll be doing kind of like checks here and there that they may be measuring how dilated the cervix is. And so typically once you hit that 9 to 10 centimeter mark, contractions are also speeding up, and you will feel that there. No, Andrea, you did not miss it. I didn't talk too much in depth about contractions and timing. There is certain stages. Oh gosh, I would have to, I think, look it up just to remember the differences between like the pre-labor, the stage 1 versus the stage 2. But if I am not mistaken, the stage 2, or when you're in that active labor, you're doing the active delivery, you're getting about a 60 to 90 second contraction that's occurring every 1 to 2 minutes, versus like when you start getting contractions, like potentially even before water breaks or after water breaks, kind of that pre-labor, they're a lot more spread out, even up until that like 30-minute mark. Now the specifics I would have to look up. I apologize. And then I did want to type, before I forget, the 2 lubrications that we love to recommend. And that was where, again, Good Clean Love and Slippery Stuff are those water-based, glycerin-free, paraben-free lubrications. Alyssa said, I've been educated on the 511 rule. Go to the hospital when you are having contractions every 3 to 5 minutes that are around 1 minute for the last hour, but talk with your OB. Yeah, that's perfect. Yep, love the slippery stuff. Will the slides be shared? I'm hoping to share the recording with you guys. With actually that being said, if anyone would not like a follow-up email, please individually message me in the group. But I believe I should have all of your emails based on the sign up. So I will try and send that out. And if for some reason the recording is not sharing, I will share my slides. So that way you guys just have them for your reference. Okay. Yeah, great question. I'll try and do that sometime tomorrow. Great. Actually, I'm going to stop the recording. Oh, maybe not. Oh, I don't know how. Oh, there we go. Okay.